Good day, everyone. We are from Block ND-RLA Group 1, and today we will be presenting our concept map about asthma. Here is the concept map of our topic, and for the following slides, the group will attempt to interpret and explain details per part so that you will be able to appreciate it. Globally, asthma is ranked 28th among the leading causes of burden of the disease and 16th among the leading causes of years lived with disability. The prevalence of asthma symptoms in children is 14%. Asthma was acknowledged as the most prevalent chronic respiratory disease worldwide. In 2016, the Global Burden of Disease or the GBD study estimated that there were 339.4 million people worldwide affected by asthma, and it is now recognized as one of the most important non-communicable threats to global health, social welfare, and economic development in all regions of the world, especially in low to middle income countries. Focus and accelerated efforts are required to make asthma a lung health priority. For a brief description, asthma is a disorder that causes your airways to constrict and swell, as well as create excess mucus. These can make breathing difficult, resulting in coughing, whistling or wheezing on exhalation, and shortness of breath. Asthma is a mild annoyance for some people. For others, it can be a major issue that prevents them from going about their daily lives and can even lead to a life-threatening asthma attack. Although asthma cannot be cured, its symptoms can be managed. Because asthma symptoms may vary over time, it's critical to keep track of your signs and symptoms with your doctor and alter your therapy as required.
Here are the predisposing factors of asthma. First, genetics. Inherited genetic makeup predisposes a kid to have asthma. It is believed that 3/5 of all asthma cases are hereditary. Next, child's medical history. Some children who experience viral respiratory infections go on to develop chronic asthma. Next, sex. Childhood asthma occurs more frequently in boys than in girls. It is unknown why this occurs. However, some experts find young males' airway size to be smaller compared to the female's airway. Next is environmental exposure. Exposure to the main component of smog or ozone raises risk for asthma. Those who grew up or live in urban areas are at higher risk for asthma. Next is obesity. Children and adults who are overweight or obese are at greater risk of asthma. Obese patients often use more medications, suffer worse symptoms, and are less able to control their asthma than patients in a healthy weight range. Next is maternal smoking. This results in lower lung function in infants compared to those whose mothers did not smoke. And lastly, premature birth. Preterm birth is related to a deficit in the structure and function of the lungs, which may increase the risk of subsequent asthma development.
Asthma is characterized by bronchial hyperresponsiveness. This feature of the asthmatic diathesis predisposes patients to wheezing in response to a number of different factors. These precipitating factors include specific allergens and irritants, may also work through non-specific manners such as exercise and hyperventilation. Respiratory infections also commonly provoke asthma, especially in infants, and may indeed precipitate the asthmatic state itself. Drugs can also often trigger asthma attacks, and the mechanisms of asthma precipitated by non-steroidal anti-inflammatory drugs such as aspirin have been the subject of recent research.
The airways have a layer of smooth muscle in their wall, which enables them to constrict or dilate. In people suffering from asthma, these airways are inflamed, narrowed, and become more sensitive to certain substances. Mucus secretion is also increased, which further obstructs the airways. Causes of asthma are complex and not fully understood, but likely involve a combination of genetic and environmental factors.
The signs and symptoms of asthma in children include: first, a cough that doesn't go away, coughing spells that happen often, less energy during play or stopping to catch their breath during activities, avoiding sports or social activities, having trouble sleeping because of coughing or breathing problems, rapid breathing, chest tightness or pain, wheezing or whistling sound when breathing in or out, seesaw motions in the chest or what we call as retractions, shortness of breath, tight neck and chest muscles, feeling weak or tired, and having trouble eating or grunting while eating in infants.
Here we have the nursing diagnosis. For the first nursing diagnosis, we have ineffective breathing pattern. It is defined as the inspiration and or expiration that does not provide adequate ventilation. It may be related to increased production and retained pulmonary secretions, bronchospasm, decreased energy fatigue, possibly evidenced by wheezing, difficulty breathing, changes in depth and rate respiration, and use of accessory muscles, and more. Then we have the treatments. We encourage sustained deep breaths because this technique promotes deep inspiration, which increases oxygenation and prevents atelectasis for the patient. And then we place the patient with proper body alignment for maximum breathing pattern because the sitting position permits maximum and lung exertion and chest expansion. Then we have the nursing diagnosis activity intolerance. It is defined as the insufficient physiological and psychological energy to endure or complete required or desired daily activities. It may be related to imbalance between oxygen supply and demand, possibly evidenced by fatigue and exertional dyspnea. For its treatments, we increase exercise or activity levels gradually, then teach the patient the methods to conserve energy, then plan care to carefully balance rest periods with activities to reduce fatigue, and then reduce intensity level of activities or the discontinued activities to prevent overexertion of the patient. Another nursing diagnosis would be impaired gas exchange. It is defined as a condition where there is an alteration in the balance between the exchange of gas and the lungs. It may be related to altered delivery of inspired oxygen, air trapping, possibly evidenced by dyspnea, restlessness, and abnormal skin color, and more. Then for its treatments, we check the hemoglobin levels because low levels reduce the uptake of oxygen at the alveolar capillary membrane and oxygen delivery to the tissues. And then we monitor chest x-ray reports because chest x-ray studies reveal the etiological factors of the impaired gas exchange. Then lastly, we have the nursing diagnosis, the risk of contamination. It is possibly evidenced by the risk factors of presence of atmospheric pollutants, environmental contaminants in the home, for example, smoke or secondhand smoking of tobacco. For its treatment, we promote a clean environment to prevent the patient from inhaling polluted air or environmental contaminants such as smoke, and then we teach the patients to stay away from secondhand smoke.
In health management, stay away from allergens and tobacco smoke. Smoke irritates the airways, causing them to become swelled, narrowed, and clogged with sticky mucus, much like an asthma attack. Allergen exposure can cause inflammation in your airways, increasing the likelihood of an attack. Nebulizers are very useful for administering asthma treatments to newborns and young kids. They are also useful for children who have problems using an asthma inhaler or require a high dose of an inhaled drug. Bring and use the doctor-prescribed inhaler everywhere you go. Inhaler helps relax muscles that tighten around the airways.
Asthma can be hard to diagnose. The child may require tests to rule out other conditions and determine the most likely cause of his or her symptoms. The following are the tests that the child might need. First is the lung function test or spirometry. It measures how much and how quickly a child can exhale. Another lung function test is bronchoprovocation. Using spirometry, this test measures how your lungs react to certain provocations, such as exercise or exposure to cold air. Lastly is exhaled nitric oxide test. If the diagnosis of asthma is still uncertain after lung function test, the doctor may advise measuring the level of nitric oxide in an exhaled sample of the child's breath. However, the asthma tests used are ineffective before the age of 5. In the case of younger children, the doctor will rely on information provided by the parents and children to provide information about symptoms. Sometimes it takes months or even years to make a diagnosis after observing symptoms for months or even years.
Once a person's airways become sensitive, they remain that way for life. About half of the children who have asthma have a noticeable decrease in symptoms by the time they become adolescents, therefore appearing to have outgrown their asthma. However, about half of these children will develop asthma symptoms again in their 30s or 40s. Unfortunately, there is no way to predict whose symptoms will decrease during adolescence and whose will return later in life. By learning about asthma and how it can be controlled, you take an important step toward managing your child's disease. Work closely with your child's asthma care team to learn how to avoid asthma triggers, what medications do, and how to correctly give them. With proper care, your child can live free of asthma symptoms and maintain a normal, healthy lifestyle.